I wanted to really just spend a little bit of time telling you about our experiences of using telehealth and telecare, those remote monitoring devices, which I'm sure some of you have heard quite a lot about and some are still wondering what it is. But before I do that, I wanted to just start by saying why we're interested in the whole idea of transforming health services for these groups of people with long-term conditions, chronic illnesses. And as you can see there from some of those facts that I've put up there, we're looking at least 15 million people in England. It's probably more than that with some of the way that people live in institutions as well. So we're looking at a large proportion of people who use a lot of our services, who are costing us around 70% of all of the health and social care budget. And this isn't something which is unique to us, it's common to health services around the world. But we are very conscious of the fact that the majority of that expend is in the hospital sector. And we wanted to know whether or not you could use some of the new technologies that were emerging back in the sort of late 90s, early 2000s, as to how you could use that to help reduce some of that burden. So we started looking at something called the Whole System Demonstrator Programme, which was and still ongoing actually in terms of the evaluation, a randomised controlled trial looking at telehealth and telecare. It's randomised around the GP practice area, and we had 238 GP practices involved, and through that we managed to recruit over 6,000 people to this study, making it by far one of the most complex and if not the largest randomised controlled trial of anything in the world, certainly the largest of telehealth and telecare. But we wanted to make sure that it was transferable. So we're looking at 3 different diseases, so heart disease, respiratory problems and diabetes. And we wanted that evaluation to be independent. So we recruited 6 of the leading academic institutions around the country to help us do that. And we had a mixture of urban, rural and mixed economies in order to be able to say, well, if it works here, we can at least say there are some benefits to people elsewhere. So it was a rigorous process to get not only the trial established, but a rigorous process to recruit the number of people that we got. And as you can see from the slide there, it ended up with 6,197 people. And that includes a number of those who are carers rather than just people who are using the services. And they were equally split between telehealth and telecare and equally split between control and intervention. So we're still evaluating all of the many millions of pieces of information that you can generate over at least 12, 18 months. Some of these people were on the programme. But we have published our first set of results on telehealth. And these were in the British Medical Journal back in, I think it was June, it says on the 22nd of June. And this is really where we started to understand what was going on with the results. And we saw this back in the department back in last summer. So it gave us confidence to say there's something really unique going on. And I just wanted to show you this table because this is the one that certainly lit our imaginations. And you can see all the various confidence intervals in there, which gives confidence that we know that these results are not just the fevered imagination of 1 or 2 people. But look at the far left-hand side, or far right-hand side from you, rather. We were seeing the difference between control and intervention around a 45% difference in mortality. So that gives you some level of confidence that there is an ability to reduce mortality. And the same for the numbers around emergency admissions. It's 20%. The difference is quite amazing. But we also, if you run down those numbers, you can see things like elective admissions, 14%. You can see the number of bed days, 14%. So what it's telling us is that using telehealth in an integrated fashion should give you an opportunity to reduce activity, reduce demand, and give you the freedoms to start thinking about things differently. What it also told us is that at the cost base that we were looking at back in 2008, it was quite an expensive way of doing this. So the return on the investment is actually not as big as some people were hoping. But that's a really important finding because whilst we got the major change, we also started to realise there's something needed to be done about that cost base. And even on this study, you can see at the high cost, we were still getting something like £180 per person per year. But that wasn't really going to give you the return on investment that we were needing. And that's not giving people the confidence that this is really going to be worth investing in. But our argument has been, look at the opportunities here and let's try again on how we get the cost base. I've got a musical accompaniment, this is rather good. Never had that before. So just concentrating on the results, we started to think, so what next and how do we get there? How are we going to do something which is innovative to change that whole dynamic around the cost base so that you can realise the benefits at a cost which is going to really benefit everybody? Now at this point, thank you. At this point I'm going to hand over to Miles Ayling, who's Director of Innovation in the department, who will tell you a little bit about how we are going to do this and what programmes we're actually building. So Miles.
Thank you, Stephen. Morning, everyone. WSD is a great piece of work, great results, presents a great opportunity. I don't think there's any question that assistive technology, telehealth, telecare, telemedicine will transform the way we deliver healthcare globally over the next couple of decades. It's not a matter of whether, it's a question of when. But it won't be plain sailing. One of the things Stephen's already alluded to, some of the results from the whole system demonstrator trial showed that at existing prices and existing volumes, a few thousand here and there, telehealth was unlikely to be cost effective. So we need a much lower unit cost and we need a much greater volume to make telehealth anything other than a niche market. And that's just what we're attempting to do with our 3 Million Lives campaign. That's been designed to improve the quality of care, the quality of life and the life chances of 3 million people living with a long-term condition in the UK. And that 3 million targets over the next 5 years. Now, of course, it's more than just cost and it's more than just volume. There are a lot of other very, very important factors that will determine whether or not we succeed. The time's limited today, so I'll just go through 3 of the most important ones. Firstly, and really importantly, we need to understand this is as much about culture and people as it is about the technology. There are lots and lots of examples up and down the country of people buying technology and it lies unused in people's homes or on shelves in warehouses. The technology is the last piece of the jigsaw, not the first. What comes first is the design of services that you wrap around the technology that allow you to deliver high quality care in the community or in people's homes. And that's tough, and it's tough not just because it requires considerable expertise to redesign services, but because you're going to be changing and affecting people's jobs, how they do those jobs and where they do those jobs, and that's never easy. It also means retraining clinicians, it means educating and building support amongst patients and their carers, and it means changing contracts and deals between purchasers and providers. And it's only when you've done all of that you can start to think about installing the technology. And it's only if you have all of those elements in place that you'll get anywhere near the 3 million target that we've set ourselves. Secondly, we need a completely different relationship with industry, particularly in the NHS. The scale of what we're attempting to do, 3 million, is by an order of magnitude greater than anything, anyone, anywhere globally is attempting at the moment. And that's just way too big for either the public sector or the private sector in this country to do by itself. We need to work together in order to deliver it. But the relationship has to change. We need a relationship that's based on trust, not transaction. We need a relationship that's based on ambition, not caution. That's why it's 3 million, not 30,000 or 300,000. We need a partnership that's based on mutual, not vested interest. And importantly, we need a relationship that's based on shared savings models rather than the traditional capital or revenue investment models. Now, that's really difficult for industry because they have to take some financial risk. And that's a significant financial risk. But if they don't, they haven't got skin in the game. We also need to work with industry to provide support to the NHS. What we're describing is an absolutely massive change programme. There's no denying that. It dramatically changes the way we deliver healthcare in the NHS. People don't have the skills, they don't have the capacity, they don't have the capability to do that at a local level. So we'll have to work together with industry to combine our resource, to combine our expertise, to combine our knowledge, to combine our field forces to help the NHS prepare and get ready to deliver that change. Even then, it's going to be incredibly difficult. Thirdly, and the last point I'll cover, and probably most important of all, you need an absolute commitment at all levels to make this succeed. That's the politicians, it's the policymakers, it's the healthcare managers, it's the bureaucrats, it's the clinicians, it's patients, and it's the carers. If you don't have all of those people on side and supporting what you're trying to do, you really might as well not start. And a good example of that is, despite the results Stephen's just walked us through for the whole system demonstrator programme, which is the largest randomised control trial of assistive technologies ever undertaken, there are still people who say we don't have an evidence base, or we don't have enough evidence, or the case isn't proven. So we clearly have a job to do to build support, to build understanding, to build knowledge, and to build advocacy. Just as importantly, we also need to make telehealth, assistive technology, 3 million lives, a priority for the NHS. If it isn't, it won't happen. And that's just what we've done. 3 million lives was included in the operating framework for the NHS, so it's now non-negotiable. Everybody has to do it. It was also one of the high-impact innovations in Sir David Nicholson's recent report, Innovation, Health and Wealth. So now it's everybody's business. But it will still be a challenge. I just want to leave you with one last thought. You also need a relentless determination to make this happen. Almost every day, people will find reasons why you shouldn't do what we're attempting to do. And what you've got to remember is why we're doing this. It's the patient. You know, you look at the figure that Stephen quoted about reduced levels of mortality for people that use this technology, and that, for me, makes the case, if nothing else does. It's an enormous task, it's an enormous challenge, it will be enormously difficult, but if you get it right, and if we get it right, the benefits are potentially enormous. So that's all I wanted to say. Thank you for listening. I'll now hand over to Professor Gillian Lang, who's the Deputy Chief Executive of the National Institute for Clinical Excellence.